I would like to welcome you all to the Endocrinology Journal. Today we will start the opening with Dr. Ihab Al-Tunger, consultant endocrinology from Prime Hospital. Dr. Ihab, the floor is all yours. Thank you.
Thanks, Diana. Good evening, everyone. We know each other, all maybe some new guests. I welcome all new doctors joining our club. Actually, we have a summer, we like pause for 2 months, so we're resuming after June. Hopefully, every month we'll resume the journal. Actually, before I start, I will take a chance because this is when we started the idea of journal. It's like club monthly meeting, but it turned to be a real journal. So we have a journal. It's advanced in obesity, endocrinology, and diabetes IDOS. We'll hopefully in October, first week of October, we'll publish the first issue. We still there is 2 places. If someone wanna publish, it could be original article, it could be review, editorial, it could be case report. But just we are rushing, so like 1st of October, and it's free. I just want to confirm. Okay, so be happy.
Anything or only endocrinology?
Well, actually, it could be if endocrinology, like something with like pregnancy with diabetes, GDM. It could be hypothyroidism in pregnancy, but something with the theme of the journal is obesity, diabetes, or with any other specialty. We'll talk. Now, first, I will go for this is a link for the journal. I will forward in the group, and this is our program for today. We'll start with Merck representative. They will speak about role of metformin in diabetes prevention by company. After that, we have a very nice, interesting talk by Professor Ali. It is very interesting subject about pre-diabetes and windows of opportunity to prevent. Each speaker have 15 minutes. Sorry for just to confirm for the time. The second speaker, Dr. Hadoun, a very interesting subject about the use of T3, pros and cons. And we've been in talk for this arranging. So yeah, I wanted to make it like role play, like some of our who support T3 and some who against. But we don't have time. We were in the summer, so Dr. Hadoun will play both rules, the pro and the con. We'll finally go for our third speaker, Dr. Karsi. He will speak about very interesting topic, resistant hypothyroidism, because also this nice, interesting topic we face. We increase the dose of thyroxine all the time, and then sometimes we couldn't control. So it seems it's a medical issue. After that, we'll have 15 minutes for question and answer, and after that, the dinner. I hope we finish 10:15. Otherwise, everyone will lose the dinner. Okay, so I will start with Muhammad Ammar. Merck for giving a nice presentation, 15 minutes each one.
I think I have to finish at 9:15. I have 1 minute.
Thank you.
Thank you, Doctor. Thank you, Dr. Ihab, again for giving us the opportunity as Merck team to be part of this. What I'm going to share with you is something that you most probably you know it very well, which is diabetes prevention, and a couple of updates about the role of metformin and the most recent latest updates in the world. Where's the clicker? I have to present from here.
No, you have it. No. Yeah, yes.
Thank you. So the first slide is showing the tip of the iceberg is type 2 diabetes, and as you know, all of you know that pre-diabetes is impaired fasting glucose, impaired glucose tolerance. It's all about the hyperglycemia or hyperglycemia. So it's the dysglycemic continuum always starts with the glucose intake that we have. The more glucose intake, the more insulin secretion we have, and the more pro-insulin secretion. And this, by default, will end up by increasing in free fatty acids, visceral obesity, and definitely hepatic fat. As you can see, as you can know, all of you doctors here, and virtual doctors as well, the diagnosis starts at the full depletion of beta cell function when there is no insulin secretes from the beta cell. However, type 2 diabetes is happening far away from the onset of type 2 diabetes or the symptoms, and this red circle where we have to act urgently against prediabetes. The hyperglycemia is targeting multiple organs, intestine, pancreas, liver, muscles, also brain, and kidneys as well. So the hyperglycemia is not only targeting pancreas. One of the complications of hyperglycemia is type 2 diabetes. This is only one complication of the hyperglycemia. These ranges are very commonly known by all of you. We're looking at the HbA1c, the normal, below 5.7. The pre-diabetes range is from 5.7 to 6.4, and diabetes definitely above 6.5. This is the range of type 2 diabetes. And the question is why we should care about pre-diabetes. Because 400 million population of people, they have pre-diabetes worldwide, and we do expect to have a number of 470 million by 2030. This is a dramatic change in disease progression, but this is not the issue. The issue actually is that more than 80% of these people, they don't know that they have pre-diabetes. It's a silent disease and a symptomatic disease as well. Some of the doctors, not mostly the endocrinologists, we see many of the doctors across the Gulf countries, they wait for the patients coming from 5.7 till 6 till 6.3 to treat the patient. However, this minimal changes in numbers may impact the progression to type 2 diabetes significantly. If you look at the graph here, the patients from 5 to 5.5, they have already double risk to be diabetic. These people are normal in terms of diagnosis. People from 5.5 to 6, they have 5 times risk to be diabetic. So it's only 0.5%. And these people, if they move from 6 to 6.5, they will be having 20 times increase to be diabetic. What about the impact of prediabetes on micro and macrovascular complications? If you look at the cardiovascular risk, there is an increase of 20% versus the normal glucose. If you look at the neuropathy, for example, you will see higher percentage or higher risk by 75% versus the normal glucose. Looking at the retinopathy, there is a double risk for people below 6% versus people maybe above 6%. And chronic kidney disease risk is higher by 67% for people without prediabetes versus people with prediabetes versus the normal glucose tolerance. And the overall mortality risk increases by 41%. Definitely you are familiar with the diagnosis criteria or the testing. Whom should be screened for prediabetes? This is according to the ADA. Patients, adults above 35 years old should be screened. Overweight or obese with any of the risk factors like family history, first degree relative with diabetes, high risk patients, high rate of ethnicity, cardiovascular disease, hypertension, hyperlipidemia, women with history of gestational diabetes, women with PCOS as well should be screened, and any physically inactive patient should be screened for prediabetes. Women with gestational diabetes should be screened every 3 years, and if all the results are normal, minimum every 3 years we should screen anyone every 3 years for prediabetes. What about metformin and diabetes prevention? We're proud that we have the label in the UAE approved at 2018 because the only approved medication by label is metformin. Currently, no medication is approved for prediabetes by label, and we have the label changed in more than 55 countries worldwide. The most recent updates about metformin, why we got the approval of prediabetes, because it's targeting different mechanisms of action as anti-hyperglycemic and also as cardioprotective agent, targeting the skeletal muscle, adipose tissue, liver, gut, and also myocardium and vascularity. But the most recent updates about the mechanism of action that have been published in October 2023, that they found that metformin increased the secretion of GLP-1. This is very recent, only in October 2023. They found that metformin could increase GLP-1 secretion, so there is an impact on insulin resistance, also in gastric emptying, and also on weight reduction. This is very recent update. What about the evidence behind using metformin in diabetes prevention? We have a couple of studies that you are familiar with, and there is very recent study as well. Diabetes prevention program and diabetes prevention program outcome study. This is a study into three groups, study design into three groups. Patients on strict lifestyle modification, they are having 30 minutes exercise for 5 days a week, and they are doing weight reduction around 7 to 10% of their weight. Group of patients on metformin with a dose of 850 twice a day, and patients on placebo. And we have observed the patients over 3 years, 10 years, and 15 years. The results were significantly towards lifestyle and metformin. As you can see, doctors, that lifestyle modification as the cornerstone reduced the incidence of prediabetes by 58%. No medication can achieve this ever. The lifestyle modification is always the gold standard to prevent type 2 diabetes if the patient can tolerate a strict lifestyle. Also, metformin achieved 31% reduction, and the most important note that you are, as an expert, as endocrinologist, should disseminate it to maybe the juniors or mid-seniors physician, the dose of metformin in prediabetes. Because the dose used here was 850 twice a day, and we see many of doctors, they use suboptimal dose. 500 twice a day, one tablet of 750, and this is very common across the Gulf countries. Another study, which is the Chinese prevention program, where metformin showed significant results, up to 65% reduction versus the control group. And we have the most recent updates about the Chinese diabetes prevention program, and we had no study before compared metformin at the beginning with lifestyle. Always, all the studies already look at metformin as an arm and looking at the lifestyle and comparing them to each other. But in the Chinese diabetes prevention program, they found that as an addition from the beginning, metformin to lifestyle modification, there is extra 17% reduction in incidence of type 2 diabetes. So we encourage everyone to look at the patient. If the patient is willing to do a lifestyle modification, well and good. In addition to that, if we started metformin, you will have extra 17% reduction for diabetes prevention. I'm not going to go with the subgroup analysis because of the time, but this is the Indian diabetes prevention program, and this is very interesting study because they split the patients into 4 groups. The control group, definitely, patients on strict lifestyle modification achieved like 30% reduction. Patients who didn't do any lifestyle modification, only with metformin achieved 26%. And patients with on and off lifestyle modification, which represents us. Everyone in this meeting room and virtual connected, they have a lifestyle modification. Sometimes we take care of our exercise, we take care of our food, and then we off that because of maybe the summertime, as Dr. Ihab mentioned. So we are on and off lifestyle modification. Means when you secure to your patient metformin as a baseline or as an addition to that, mostly you will achieve the same results with your patients. So you have the 3 options according to the patient willingness and according to the patient maybe lifestyle or supporting group that you have. This is the guidelines, the Emirates Diabetes Society guidelines, looking at the pre-diabetes lifestyle modification, as we mentioned, for 6 months. However, let's test the patient every month if they are continuing the lifestyle modification or not. If not, we have to treat them to add metformin with 1,500 milligram a day for 6 months. Repeat the diagnosis after 6 months. If the patient develop, we have to treat them as type 2 diabetes. If not, this is the objective of diabetes prevention, is to keep the patients below 6.5. Because we had this question before in such a discussion, and one of the doctors expected with the regular use of metformin to have the patient to normoglycemia. However, one of the endocrinologists answered the question that the success in diabetes prevention is to keep the patient within the pre-diabetes range. No high expectations to go with the normoglycemia. Sometimes patients achieve diabetes remission and go to normoglycemia, and some of the patients not achieving this. So the success in diabetes prevention is to keep the patient below 6.5. The last most important thing about metformin is that metformin by nature is a dose-dependent medication. The more we increase the dose of metformin, the higher HbA1c or fasting plasma glucose reduction we will have. Because this is a very common, and you can confirm this, Dr. Ihab, that some of the doctors, they are using suboptimal dose, and this is the impact on fasting plasma glucose. The second recent update that we have now in the UAE and in the rest of the Gulf countries, that we have the label of metformin approval in pregnancy. Previously, we didn't have the label of type 2 diabetes pregnant women, but now we have the label. You can start from trimester 1. If you have a patient, type 2 diabetic patient, is planning to get pregnant, or she got pregnant while she is on medication, you can use it. We have the insert leaflet change. We don't have yet the approval for PCOS, only in 5 countries, and we are in the process in the UAE. But most commonly, doctors are using it as off-label indication. But we are, as Merck, we recommend to you to use metformin in type 2 diabetes pregnant women. You can use it as add-on to insulin. You will have extra benefit of HbA1c reduction, less insulin units, and less weight reduction. The last thing, glucophage XR, definitely it's better than the immediate release one because it's unique with a unique gel chain diffusion system. As you can see here, this is the tablet of glucophage. There is an outer gel surrounding the inner polymer matrix. Once the patient swallows the tablet, the gel swells in the duodenum, and all these polymer matrix or the inner polymer matrix stays in the duodenum, slowly releasing metformin. And this is impacting the absorption. This is a comparison between the extended release, the glucophage XR, and the immediate release metformin. It's covering the 24 hours, slowly absorbed to the bloodstream, impacting the patient adherence. 97% of the patients are adhered on glucophage XR, with 53% less in diarrhea and 70 in GI side effects, and 77% less in diarrhea. We do recommend 2 tablets of the 750 XR for pre-diabetic patients once daily at the evening time, and 2 tablets once daily for type 2 diabetic patients. I hope I was clear and crisp. So I finished on time exactly, 14 minutes. And thank you so much, doctors, for your attention. Thank you.
Thank you. Very, very productive. Now it's my honor to introduce Professor Ali Honi, FRCD consultant endocrinologist in Burjili Specialty Hospital. So he will be briefing us about reversing prediabetes, windows of
Sorry, same one?
Yeah, first we all the same.
Thank you so much. Thank you. Thank you, Dr. Ihab, for the invitation. This is I'm a newcomer to the club. I wasn't expecting this crowd, to be honest. I was rushing this presentation in the last minute. And thank you, Dr. Mr. Muhammad Ammar, because you did everything for me. I don't think I should be the first one to.
This is theoretical.
No, yeah. No further ado, I just go. This is a chance. Pre-diabetes is a massive problem. It's a massive problem. And this is what I tell my patients in the clinic. This is a time when you can reverse. And instead of going to diabetes, you can go back to healthy status. Learning objectives, and that's what we're supposed to present when we take medical students. Apology, this is too simple. Learning objectives is something we need to. Let's speak about statistics of pre-diabetes. It's a massive problem. 1 in 10 should have this pre-diabetes. And this is the chance to stop things. By the way, I tried to put some slides from the last ESD this month, this very month, September, because they spoke about machine learning and artificial intelligence and how you can stop prediabetes from progressing to diabetes. Very nice presentations. It's freely available from ESD, the web page. So it's a chance to see it. It's really nice. None of anybody being to ESD haven't, but nice stuff about how to stop prediabetes progressing to diabetes. So I tried to, in the 15 minutes, try to pass through all those. Sugar. Heterogeneity of defining prediabetes is a problem. Because you find different regulatory bodies defining prediabetes in different ways. So it could be, for instance, the hospital workout is saying prediabetes as their HbA1c starts from 5.6. When I did some literature research for this presentation, it's 5.7. I don't know how you practice. You include 5.6 or 5.7? Top point? Above 5.6. Okay, so 5.7 and above.
No, because sometimes it's like above.
Then 6.4, isn't it? Yeah. So there is ways of doing postprandial, 2 hours postprandial, fasting plasma glucose. So you choose and pick, which one you want. The bottom line is massive numbers. And basically, if you do diabetes clinic, most of the cases are pre-diabetes, and that's what you see. We tell you about weight gain, broken weight, and then first thing I write is pre-diabetes.
It was 140 fasting before 1997, diagnosis of diabetes. When we see patient fasting 130, we say you are more diabetic in that time. Before 1997.
140.
The cut-off point for fasting was higher than.
It's 126.
Yeah, like almost 20 years.
We have more cases, more problems. I think this window is important. That's why you don't want them to have diabetes because cost. This Chinese University of Hong Kong, it costs somebody to progress from pre-diabetes to diabetes per year about 6,000 if you change it from Hong Kong dollars to US dollars, 6,000 per year. Cost of treating diabetic. So that's why it's a window to stop this happening. Anyway, so Middle East, MENA, has major problem, the orange color. Okay? So see, you can compare it with other continents. So nearly 64 million. Again, the heterogeneity of defining pre-diabetes varies from all this. Most recent one is 88. This is what happens when you work in your USD, try to change slides, you get it happening again. Why it's important? Most of the studies suggest that between 5 to 15% of individuals with pre-diabetes will develop type 2 diabetes each year. That's that number. 5 to 15%. Depending on their ethnicity, more in African American Hispanics. So ethnicity is important, BMI, there's risk factors you need to look at. And that's how they do this artificial intelligence and machine learning to tell your patients that your chance of going to diabetes is so high. And as I said, there's many papers presented in this ESD this month, September. In fact, one of them in the 10th of September in the ESD site. Now, I'm not going to dwell too much on the standards, but there is sections in the ADA standards of medical care of diabetes, the American one, about pre-diabetes, what it's supposed to do with section 3. And this is the grading of the evidence on what it's supposed to do, must do, and what risk factors you look at. Like when the age is more than 45, family history, cardiovascular disease, the way as Muhammad said, it's a high chance for cardiovascular disease. You don't need to go into diabetes to have a high risk of cardiovascular disease. Pre-diabetes can set diabetes. So sedentary lifestyle, members of ethnic groups with high risk, Asians, African Americans, Spanish, and this region, people with dyslipidemia, those are factors you need to look at, and that's a chance for you to do screening. Guidelines telling you this. I'm not sure I'm going to present this case study, but give you a chance to read. But 31-year-old male, no significant past medical history, referred by the workplace to the primary care physicians, elevated blood pressure, and he presented to clinic with no complaint. By the way, the other name for pre-diabetes, which I find non-diabetic hyperglycemia. Now, is it asymptomatic? Is it asymptomatic? When you look at and dive deep in pre-diabetes, there is some osmotic symptoms. There is some osmotic symptoms, blood in the vision. So it's not completely with no symptoms. There is some symptoms pre-diabetes. So don't get surprised when the patient comes to you and fulfilling criteria of defining them as pre-diabetic. And they tell you they start getting some osmotic symptoms and so on. So be aware of that. It is not absolutely asymptomatic. So just to go quick, blood pressure was high, 142 over 90. Body weight is on the higher side. I didn't work out the BMI, but using the obese side. Cholesterol is high, and LDL as well. Anyway, so what's the diagnosis here? Basically, pre-diabetes or metabolic syndrome. This is how we define metabolic syndrome. And 2 years later, patient came to clinic. 2 years later, present with complaint of decreasing frequency. Now he's obvious frank diabetes with blurring of vision, osmotic symptoms, nocturia, and lost some weight as well. Review of systems are remarkable. Blood pressure still high, pulse 80, weight still is not moving, he didn't lose much. But fundoscopy examination is important as well. You remember defining diabetes by retinopathy. That's the way we diagnose it. And that's why we're using machine learning and AI to make a diagnosis of diabetes and cross borders to diabetes. So this is what you will tell your patients, and patients become more educated and know about this stuff. And as said, this year, ESD, they had a good section of their presentation about how to diagnose pre-diabetes and what's the chances of them going into diabetes. Please read that, because I think our patients are very educated. So, medication thiazide, prevent diabetogenic, and started 1 year before that. Now fasting glucose is now very clear, random. Glucose is high. That's in the range of diabetes. Diagnosis here is fitting diabetes, which is random blood glucose more than 200 fasting. And sometimes in the absent criteria, sometimes you need to repeat testing again, don't forget that. I don't know people doing OGTT nowadays. Do you do it? Do you have time to do it? I don't do it as much nowadays, to be honest.
Do it in pregnancy.
Yeah,
Or my
pregnancy is
colleague,
the first time.
gynecologist, do it.
Exactly.
But pre-diabetes,
But pre-diabetes, I don't do that. I don't subject to that. I think before I finish here, this University of Leicester, this is a nice place. This is before the presentation ESD. This the Leicester Diabetes Risk Score. And this is exactly if you want to work out BMI, gender, ethnicity, and ask about family history and if the patient is not antihypertensive treatment. Just Google it out, Leicester Diabetes Risk Score. And that you can tell your patient in a clinic that your risk of going to diabetes is blah, blah, blah. Okay? That's it. Less than 15 minutes. Any questions?
we will leave the question for 15 minutes for all speakers. So anyone can take notes. Now for our second speaker, Dr. Hadoun. Dr. Hagoon Gambi, American Board of Internal Medicine, American Board of Consultant of Endocrinology, Consultant Endocrinology in Group Care Integrated Diabetes Center. She have a very interesting topic, the use of lidocaine.
I'm not sure what I'm doing.
Lidocaine and hypothyroidism, T3, pros and cons.
Okay.
I think 50%.
Let me see if I can find my green slides. Okay, there we go. Which the presentation you want. All right. Okay. Can you hear me without a microphone? Do I need to carry the microphone?
If you are not comfortable with microphone,
Can you hear me without it? I'm usually pretty loud. Okay, that's what my kids tell me. So yeah, so today we're going to be presenting about the use of liothyronine, which is T3, in hypothyroidism. And the reason I picked this topic is because it's kind of the topic that people usually fight about. And I'm going to try to be not biased. And feel free to interrupt me and make this as interactive as you would like it to be. Okay? So we're going to start by presenting a case. And I'm sure all of you have seen this, at least within like a couple times in the last 6 months. So we have a 35-year-old, your typical hypothyroid patient that presents to you 3 years after having a thyroidectomy for benign multinodular goiter. She's been on levothyroxine for the last 3 years. She's seen 5 endocrinologists, and you're the 6th one. And she has not felt the same since she had her thyroid out. She's complaining of fatigue, difficulty losing weight, actually gaining weight, and also of like, hair loss. You can, you name all the symptoms you would like. So, you do your part, you check a TSH. She's, her TSH is normal, it's 2, it's in the middle of the normal range, but everyone else did that. So you go ahead and you check a T4 and a T3, which I don't usually do in hypothyroid patients, but you're the 6th endocrinologist, so you have to do something different. So we check a T3, we do check a T4. Now, T4 came back to be 1.7. In a lab that the normal range added is 0.8 to 1.9, so it is within the normal range, however it's on the upper end of normal. And then you also check a free T3, and it's 3.3, and the normal range between 3.1 and 6.8. So it is within the normal range, however it's in the lower end of the normal range. So, obviously the patient is extremely concerned that the T3 is on the lower end. We all know that the free T3 assays are not as accurate as we would like them to be. But then you have those results. You do check, the baseline labs, including making sure the patient is not diabetic, she doesn't have any other reason that would explain her symptoms. Everything comes back to be fine, and the exam is normal. So what would you do? So let me ask a question. How many of you endocrinologists would actually use a T3 in a case like that, or do a trial of T3? Anyone? All right. So why are we even talking about this, right? Why are we even having this conversation today? What the debate is about? We know that a lot of our patients with hypothyroidism come to us complaining of low energy level, poor quality of life, difficulty maintaining their weight, actually gaining weight, having some cognitive complaints, mood issues, women fighting with their husbands. I hear this every day. So we think about reasons. Why would a patient who has a perfectly normal TSH and taking the levothyroxine as prescribed have symptoms? First of all, patients could really not have hypothyroidism to start with. So how many patients that come to you on levothyroxine 25 mcg daily or 50 mcg daily, and then you ask about the origin of this, like when did this start? And the patient brings you the labs before starting levothyroxine and the TSH was 4 or 4.5. Patients come to their primary care doctors with a TSH of 4 in a lab where the upper limit is 4.5, and then the primary has seen the patient 5 times complaining with the same symptoms, and he's stuck, he doesn't know what to do. So he starts levothyroxine, the patient doesn't get better, ends up in your clinic, 183, well, the problem wasn't even levothyroxine or hypothyroidism to start with. Poorly managed. We see a lot of patients where the TSH keeps going up and down, so it's like a yo-yo effect, right? So TSH one day is 7, 8, the other day is 0.01, because we're having trouble dosing the levothyroxine, or the patient is not taking it in a compliant way, or the patient gets one day PPI, the other day decides to take their iron supplementation. Sometimes just them being overwhelmed with the fact that they have chronic disease and they have to take a medicine every day. That alone can cause problems. And finally, comorbidities. The symptoms of hypothyroidism are very non-specific. So having heart failure, having uncontrolled diabetes will give you the same symptoms, but the patient, for some reason, they keep focusing on the thyroid. Some of my friend endocrinologists have mugs on their desk saying it's not your thyroid. It's just, this is how we kind of like have to deal with this. But the origin of the debate of using or not using levothyroxine in the treatment of hypothyroidism, originates from this. Some endocrinologists believe in the incomplete normalization of the thyroid hormone signaling. What does that mean? Okay, let's talk a bit more about that, physiology. So, generally speaking, average T3 production out of our thyroid is around 30 microgram per day. Out of that, 5 comes directly from the thyroid, right? And then you have around 25 that is actually being converted from T4 in the system. 20 mcgs come from D2, obviously plus minus, while 5 comes from the D1, deiodinase 1, right? So T4 to T3 can, the conversion of T4 to T3 happens in 2 places in the body. Centrally, where the pituitary and the hypothalamus are there, and this is the cause of the central feedback mechanism that we see, and also peripheral. Now, it's important to actually know that, actually there's a pointer here. So D2 is the deiodinase 2. The activity of the deiodinase 2 actually comes down with higher levels of T4 in the system. So the further you push your patient with levothyroxine, the lower the conversion of T4 to T3 happens, and the lower kind of T3 you will have in your system. This, though, doesn't happen centrally. So the higher T4 level, the more T3 you'll have centrally, and the further suppression of TSH. This doesn't happen with D1. So D1 actually, deiodinase 1, the higher the levothyroxine, the higher the T4, the more D1 activity happens and the more conversion. However, this doesn't usually happen until the T4 is really in the upper range of normal and even further than that. So it's really not uncommon that you see patients who have highish T4, lowish T3 on levothyroxine, especially if you start pushing your levothyroxine further and further. Okay, so how can we fix this? So endocrinologists who are advocates of the use of combination therapy think that, if God created our thyroid to make T3 and now the patient does not have a T3, why can't we give them T3 to kind of restore the normal physiology, right? So they do believe in the combination therapy, but what's the problem with that? The problem is that we have a lot of compounded, I wouldn't say compounded, but more like natural thyroid hormone in the market that is from disintegrated pork or beef thyroid, and the ratio of T4 and T3 in those tablets is not physiologic for the human body. So in humans, the T4 to T3 is around 13 to 1. So for every 13 microgram of T4 we would have 1 microgram of T3, while in animals it's less. So it's like 4 to 1 or 5 to 1. So if you do get a disintegrated pig thyroid and you make it and you give it to the patient, it's very likely that you would suppress the TSH. And the goal is always to keep your TSH within the normal range, right? We're not going to talk about pregnancy, for example, where we know T3 doesn't cross the placenta, and that's why you cannot use those in pregnancy. We're talking about the non-pregnant population. So if you are going to use levothyroxine, the idea is to basically try to cut down on your levothyroxine and then kind of convert that to what a physiologic gradient would be and give some T3 instead. Not everyone does it the same way, and probably none of us is wrong in the way to do it. As long as you keep the TSH stable, normal, you're probably going to be okay. So, suggested by one of the big names in thyroidology is that if you drop from 100 to 87.5, you can add levothyroxine 5 daily. I'm a bit more cautious than this when I actually do start myself. So I start at 2.5 in the morning. If I do start, and I really try not to, but if I have to, I do this. So I kind of drop like 20-25 microgram per day at 2.5, check the TSH, see how the patient is doing. I can go up to 5 in the morning. Some people dose levothyroxine twice a day, so morning and evening, trying to mimic again the normal physiology because T3 has a very short half-life as compared to T4, which is like a week, right? So if you give it in the morning, it won't be there by the evening. But what's the idea, right? I mean, why do we give it in the morning? It's because the patient needs that kind of push, right? I mean, they're feeling fatigued, they're tired, they can't get out of bed. So you give them this dose in the morning, they're up and about, and then when it's time to relax and end up in bed, you're fine. It's out of your system and you're ready to go to bed. So they did a really nice study where they actually looked at the concentration of T3 in the system after giving T3 basically to patients with hypothyroidism. And the reason they did this probably was to see, are we pushing it too much, right? Like, what is the normal dose? Because we know from very old studies that if you actually give more than 20 micrograms of glutathione, it's bad. You can actually increase mortality, right? So what they did was that they tried to do, they gave the patients 3.25 twice a day of glutathione, and they, I think it was a class study. They tried to see what's the T3 level in the plasma, and you can see here that if you go higher, like 3.25 twice a day, 5 twice a day, 10 twice a day, the higher the dose, the more fluctuations you'll see in the T3 level in the blood. But even with the highest dose, which is 10 twice a day, the levels remained in the normal range. So even with the highest peak, it didn't go beyond the normal range. And this is the base where they come and say, you can do up to 20. It's based on that, knowing that even if you give 10 twice a day, you would still probably be within the normal range. Okay, so what is the concern? What are the cons of using glutathione? Why are we worried about it? Well, we know that if you give a lot of T3, you can have tachycardia. Patients come and complain of having palpitations, insomnia, that's why I don't do it at night, okay? Anxiety, tremors, agitation, heat intolerance, basically the symptoms of hyperthyroidism. That's what you would see, right? Even though the TSH might actually be normal, the fact that you're giving this, which is a very physiologically powerful, hormone, you can get those symptoms. And it is in the pack insert as a warning in the glutathione in the UK. So I borrowed this slide actually from a very nice debate that I attended in Boston this year in 2024. And the doctor who presented this basically put a slide where he had all recent, and there are more, 17 randomized control trials comparing, LT4 versus combination therapy. And when I first looked at this, the first question, and I'm sure you guys will understand, that came to my mind, do we need 17 studies? And that's only the recent ones. 17 studies to prove a negative outcome. I mean, they were all negative, basically. So negative in all ways. Negative in effectiveness, negative in safety. So the first 5 were not enough, so we have to do like 12 more to prove this, and I'm like, well, people have money, so why not? Let's do it. So basically, if you look into the little details, some studies were big, some studies were small. I wanted to look at a couple things. One would be the dose. If you notice that the highest dose done here was probably 25 there. In 2003, Sauka had a study where they did 25, that the total dose was 25. That was the highest, but everyone else did a lower dose than that, right? And if you look at them and you read the abstracts, you'll see that there was no difference in effectiveness, all the same. If you do, thyroid levothyroxine or combination therapy, there were no difference in effectiveness. There was also no difference in safety. So it is safe. So the worry about it causing problems, as long as you dose it right and you don't push the TSH low, you're probably going to be fine. And then they presented also those really nice 3 studies that were long-term studies, because the argument with the 17 studies was that they were short studies, so they didn't follow up the patients for years. So if we're concerned about cardiovascular disease and mortality, we're not going to look at the patient for the next year or so, right? We want to look at 5, 6, 7, 8 years. And that's what they did. So they looked at the patient over years of using glutathione. And by the way, some of those patients were older patients. So you're talking about your 65, high-risk patient with cardiovascular disease, and they still were fine. So there was no difference in safety. Okay, but then they looked into patient-reported outcomes. So what does that mean? So basically, they asked the patient questionnaires, right? Hypothyroidism symptom questionnaires, and there are probably, I don't know, 10 of those in the market somewhere. And each study is a different one. So there was no difference. Again, there was no difference in their symptoms in the group that took the combination therapy versus the group that took only the levothyroxine. The only thing that was a bit different was that, the patients who took the combination therapy as in a blinded study, they preferred the combination more. So this was the only significant result that was positive that came out. So 52% preferred. Now, the doctors that are against, like the argument against this was that was it truly a blinded study? Now, it is blinded. Patients don't know that they're taking liothyronine or not. But liothyronine has a very strong effect in the body. So if you take it, you feel like you got a hit. So they knew it was not placebo. So there's an argument that maybe they were not as blinded as we wanted to be. Now, the other issue was that people who get liothyronine probably had a lower TSH. Within the normal range, but probably a bit lower TSH. So was that the reason? Was the reason they felt better or they preferred it? Was the reason that they pushed the TSH a bit further low, right? So could we prevent this? Like, why don't we just use them if the TSH was the reason? If pushing the TSH lower in the lower normal range make patients feel better, so why don't we just do this with the levothyroxine alone? Why do we need liothyronine? Or do we not know how to dose levothyroxine? Obviously we do, right? So there were further studies to look at, titration of levothyroxine to tighten the control of TSH to the lower half. Did it or did it not improve symptoms? So they actually had a really nice randomized control trial. They had 56 long-standing patients who had long-standing hypothyroidism, and they gave them for 8 weeks each block different dose of levothyroxine. Lower dose, middle dose, high dose, to keep the TSH within the norm. However, so basically the TSH was in the lower dose was 2.8, and then 1 in the middle dose, and with the high dose was 0.3. And interestingly, there was no difference in patient-reported outcome. Patient did not feel better with a higher dose of levothyroxine. So now we know the message from this study was that fine-tuning of levothyroxine does not improve symptoms, probably, and it's not evidence-based. And more levothyroxine does not make you feel better. And this is something that we probably should be telling our patients more about. But this is another study that I found interesting. They had 38 patients who had total thyroidectomy for differentiated thyroid cancer, and only patients, and they tried levothyroxine and they tried combination therapy. This study was positive, so patients who had combination therapy felt better from a hypothyroid symptom perspective, but only if they had very strong hypothyroid symptoms. So if their symptoms were mild, they felt no difference. But if their symptoms were very strong, then they benefited from combination therapy. So after all those 17, 18, 19, God knows how many studies of combination therapy, guidelines started to kind of change little by little, right? So initially in 2012, the ETA guidelines said that patients on levothyroxine, a trial of liothyronine and levothyroxine can be attempted. And if you read it more in the 2014 ATA and then 2018 NICE to 2020 ATA, ETA, BTA guidelines, you'll see that people are getting a bit more relaxed about using liothyronine, not worrying about it causing cardiovascular morbidity, mortality like we used to worry about in the past. But now from further, so at least what we can tell is that those studies kind of reassured us that if we use it, keeping the TSH within the norm and not pushing the dose high, we're probably going to be okay. We're probably going to be safe. So back to my patients. So I tried 2.5. I cut down the dose of levothyroxine from 100 to 75. I tried 2.5 in the morning. The patient felt better. I'm not sure if it was placebo, but it worked. I'm happy. So we're good. The patient was happy. I was the sixth and final endocrinologist at 16, and we were all good.
Question after the last, just right there. We have 15 minutes for all questions.
Oh, later.
Yeah, later. Now, our last speaker, Dr. Garci, is the endocrinologist at Eureka Hospital. We'll speak about resistant hypothyroidism. We have 15 minutes only. Then we have 15 minutes for all questions.
Yeah. So thank you, Dr. Jeffrey, for that wonderful talk. This is in some ways analogous to that talk. What is refractory hypothyroidism and how do we deal with it? That's the focus of my talk today. First of all, refractory hypothyroidism, is biochemically defined as somebody who's taking twice their body weight of thyroxine doses and still not feeling quite okay in terms of biochemistry or in terms of clinical symptoms. Now, whether this is based on the regular weight or the lean body mass, there are some doubts, but since weight is much easier to measure, we can say that if somebody weighs 50 kilos and requires more than 100 micrograms of thyroxine, that's something abnormal. We need to look into that and find out why it has happened. So there are two types of so-called resistant hypothyroidism. Number one is a persistent biochemical abnormality. Patient takes the tablet, but the TSH or the T3 is not quite there yet. And the second is the persistent clinical symptom, like the case Dr. Jabri shared last time. So how common is this? Depending on the study we see, it could be as low as 3% or as high as 15%. Just to make this topic sound a little more exciting, I'll put the higher end of the thing. It's about 15%. How we define it, it could be based on low T3 or high TSH or combined, but it's not as uncommon as it was previously thought. So getting back to the basics, this is how thyroxine is absorbed. It's primarily absorbed from the small intestine with a bioavailability of 70 to 80%, but there's a lot of inter-individual variability. It could be 60 to 80, 70 to 80, like that. It reaches its maximum serum concentration in about 2 hours, and the T half varies between those with hypothyroidism and those who don't have hypothyroidism. There's a bunch of stats there, numbers there, but the thing that we are interested in is, especially when we are dealing with a patient with resistant hypothyroidism, is the journey that thyroxine tablet takes inside the patient's body. So first, the patient has to take the tablet. The tablet has to be stored properly. It has to be of reasonable quality. And then it enters the patient's mouth. It goes to the stomach. Here, the sodium part of sodium levothyroxine kind of disintegrates from it. And for that, acid is required. And after that, it goes to the jejunum and ileum, the small intestine, which is where bulk of the absorption happens. Everything else is in the post-absorption phase. It goes to the liver, gets conjugated, deiodinated, and then binds to proteins, and then reaches the target organs. So this part is where most of the problem happens, and this will be the focus of today's talk. So what if there is a block in the journey of thyroxine from the tablet to the patient's pituitary gland? What happens if there is a block? Now, there could be an input problem where drug quality could be questionable, storage could be a problem where the tablet should not be exposed to heat, moisture, or direct sunlight. And the biggest of them all is the complaints. The patient may not be actually taking the tablet, not merely missing it, but there could be an underlying psychiatric illness which makes the patient kind of miss tablets. So this is the usual issues. And apart from that, there could be absorption issues where the problem is in the lumen of the GIT. It could be taken along with food, a variety of things that can interfere with absorption, or with drugs, or it could be at the level of the wall of the GIT where malabsorption could be a problem. Post absorption also can result in resistant hypothyroidism where tissue conversion from T4 to T3 could be abnormal, pituitary gland abnormalities like rarer ones like hemangioma, RTH, resistant thyroid hormone, nephrotic syndrome, Addison's, etc. But these sort of stuff are, one, they're pretty rare, two, they're mostly apparent. So this is not going to be inobvious as such. So the left half of the slide is what we are actually interested in. And if we rule out all of this, input problem, absorption problem, and the action issues, finally it could have something to do with the lab itself, the assay problems, that again needs to be looked into. So when we suspect a patient to have resistant hypothyroidism, taking large dose, nothing is working out, the blood tests are still abnormal, then we do something called a levothyroxine absorption test. This levothyroxine absorption test There's no standard one size fits all levothyroxine absorption test that is universally accepted. The common numbers quoted are somewhere between 600 to 1000 micrograms of levothyroxine is given, and serial samples are taken, and then we look for increment in free T4 levels, peak value of free T4, or percentage absorption of T4 above 60%. Any one of these numbers can be taken. But before doing the test, because it's a large dose of thyroxine, we need to ensure that the patient doesn't have a heart disease. Otherwise, it could result in angina or other side effects. So this is how the test is done. And if the spike is there, it means that the patient is not taking the tablet, and it's not that they are not absorbing it. But a flat line on a thyroxine absorption test means at least our job is done. We can push the patient to the next counter, which is the gastroenterology. Okay, how to we have something called a percentage absorption of T4 there. How do we calculate that? There's we do from the volume of distribution. There's a bit of numbers there. It's kind of easy to calculate. It's not some complex thing. So this one improvement, or kind of, I wouldn't say improvement, a kludgy solution to this rapid LT4 absorption test is that you just do two samples, 0 hours and 2 hours, and look for the peak T4 value compared to the baseline. If the peak T4 is 2.5 times the baseline, it means that the patient is absorbing it, and it can be done in office setups. It's quite easy to do, and this is called a 2-hour rapid LT4 absorption test, which is probably more easy to do. What if the patient is not willing for that also? Then we could have something like directly observed therapy under supervision, the same kind of thing that we have for TB back in India. These kind of things where we give 7-day doses at a stretch to the patient, one shot to the patient, and then ask him or her to do TSH in a couple of weeks. If there is a directly observed swallowing of the tablet and it results in a TSH response, it means that there is no malabsorption. Other options include different things like soft gel capsules, liquid, and all that. Those are not very commonly available, so practicality is a big question. And all of these patients who are identified to have pseudo malabsorption must be referred to a psychiatrist for a deep analysis of why they do this thing. Apart from that, anything from grape juices to iron supplements to coffee, tea, soy, a lot of things can interfere with it. So if the patient is taking anything other than water with the tablet, that is suspect and that needs to be off. Now that pseudo malabsorption, that is the patient not taking it for a variety of reasons, is ruled out. What do we do? Once we rule that out, that opens up the issue of true malabsorption, where the patient is taking the tablet but simply the GIT is not absorbing it. That could be at the level of the stomach or at the level of intestine. Primary absorption happens at the intestine level for thyroxine, but it could be a stomach problem like H. pylori infection, gastritis, gastric atrophy, etc. But by and large, when we look at all this, these are all core gastrointestinal diseases. We may not need to actually delve in depth into these things, but it's nice to know that celiac disease, some of the common diseases that we see on a regular basis, also result in malabsorption of thyroxine. The other ones like surgical causes are clinically evident, so there is nothing inobvious about this. So this is the area that we need to focus on. H. pylori infection, celiac disease, and lactose intolerance. These are some of the common problems. So a variety of drugs either at the gastric level or at the intestinal level, a lot of things interfere with thyroxine absorption, but they are easy to pick up, especially when we take a deep history of the drug history of the patient. Again, very busy slide, diagnosis of malabsorption, but let's simplify this a bit. Think of it like a train. It starts with resistant hypothyroidism. If the patient requires twice his body weight or her body weight, we call that as resistant hypothyroidism. We rule out the preluminal and extramural causes. That is something to do with endocrinology, something that starts with the tablet, swallowing the tablet, quality of tablet, storage of tablet, till the time it reaches the abdomen, and it should not be mixed with anything else, food or medicines. That's the pre-luminal things. The extraluminal is the post-absorption problems, the rarer ones, which are fairly easy to rule out. Once we rule out any preluminal or extramural causes, then we refer to a gastroenterologist. That's the simplified approach of the previous slide. Apart from that, preluminal and extramural, there could also be lab interference, which is also which falls in our domain. So we need to do the appropriate thing to find out if there is any lab interference. Last but not the least, there could also be increased demand, which is presenting as a slightly higher dose requirement, weight gain, pregnancy, etc. But again, most of these are easy to identify; they are quite obvious in most cases. So whenever we get the Mark Garnell slide, which most of us would have seen many number of times, this is a slide we can keep in mind whenever we see some funny or uncommon TFT. Now, up till this, we have kind of like seen where the result is abnormal. Patient is unhappy, doctor is unhappy, everybody is unhappy. This is just to wrap up some of the points which have been already alluded to in the previous presentation, where reports are normal, but patient is unhappy. You could be the 5th or 6th or 7th endocrinologist. So, what could be the reasons for persistent symptoms? It could be tissue is deprived of T3, it kind of tissue is hungry for T3, low tissue T3, somatoform disorder which is coexisting along with hypothyroidism, some neuroinflammation which could be part of the autoimmune condition itself, and a variety of comorbidities and psychosocial conditions. Now, why repeat all this? If we actually know the answer, we wouldn't need to have 4 theories and 17 trials. The very fact that we have so many theories and so many trials is that we just don't know the answer. We're just gassing around. That's the thing. But why, add one more slide and take this forward? The reason is that the pendulum has been swinging from and towards combination therapy in the last few years. In fact, the original thyroxine therapy was combination therapy to start off with. When thyroid was first given to mankind, it was a combination of T4 and T3. And then as we identified that the body can make T3 itself from T4, we started moving away, and a couple of generations of endocrinologists have become very comfortable with T4 only therapy. And now that this nagging small percentage of patients are not really happy with the T4 alone, we are again swinging back to maybe combination therapy. But in spite of all this, the trials just don't seem to validate our idea that giving T3 is good, because most of these trials are negative and they just don't seem to see. So one of the things that could explain the negative trials is what we call as Simpson's paradox, where we group dissimilar people together into one group. You might get a opposite result of what we should normally be getting. If you see here, if we look at this data set, we could say that there's a strong negative correlation as the y-axis, as the x values increase, the y starts decreasing. There's a strong negative correlation. But if you actually see, this is a binning problem. If you group 4 dissimilar people, 4 dissimilar groups, they each could be having a positive correlation, but because they are grouped together as one, you might get the exact opposite of what is the real truth. So that could be one of the reasons why T3 trials have been largely disappointing. So as they say, all happy families are alike, or unhappy families are unhappy in their own ways. What it means is that if you need 5 factors for success, and even if one of them is lacking, that dooms you for failure. So the patients who are happy with thyroxine therapy probably have all the factors that they need. The ones who are unhappy probably are not a homogeneous group, but rather a motley group, heterogeneous group of people with different disorders, and we don't fully understand them yet. That being said, we could go for combination therapy if we are the 6th endocrinologist. and that's how we do it. Maybe 2.5, 5, 10, whatever it is, but it's something worth trying if the patient is unhappy with the therapy. So to take home some messages, most cases of so-called resistant hypothyroidism are simply pseudo malabsorption. That is, maybe there's a politically correct term for saying that the patient is not taking the tablet. Our job is to identify from the mouth to the patient's tissue where the block is, whether the patient is not taking or what is happening. That's the job of an endocrinologist. If we find out that it's the patient is taking and still not getting absorbed, then we refer to a gastroenterologist. And we really hope that the patient doesn't come back, because if it's a real malabsorption problem, we don't have that many options available. The soft gel capsules or the liquids are not commonly available. So this is where we stop. So thank you so much for listening, and thank you, Dr. Hal, for this wonderful opportunity. And in case anybody likes to want this, you can just take a snapshot. Thank you.
Well, we have 15 minutes. We have 15 minutes question, so Dr. Ashur. Diana.
Hello, Assalamu alaikum, good evening everyone. I am Dr. Shara Adam, and nice to be back here. Very interesting, light lecture and uh, amazing speakers today. First of all, I would like to congratulate all the speakers. It was really very mind blowing. So I wanted to ask Dr. Hardoon. I had one similar case, like the case which was presented, and in that patient actually I wanted to start T3, but she is like 60-year-old female with TSH in the range of 1, with T4 on high normal, but T3 is actually coming one time below the range or always staying in the low normal range. Although as you said, T3 assays are not very robust. For her, the two issues were, one is that she has she's 60-year-old and she has osteoporosis. So when I read about the T3, when to be careful, the things to be careful for, there was also one osteoporosis, because it's supposed to have the same side effect as hyperthyroidism. And she's already taking treatment for osteoporosis, and she also has intermittent palpitation followed with cardiology and not having any cause for that and based on beta blocker therapy. However, she has all the other symptoms of persistent hypothyroidism like fatigue and hair fall, all of these. So I did not start because I was afraid of worsening osteoporosis and even the palpitation. So what's your thoughts on this?
So I'm not sure, to be honest, that the subgroups of patients that they checked, they gave the T3, that they actually looked into this. And I'm also not sure if T3 itself is causing the osteoporosis, or it's really just dropping to SH below 1, which we know can actually increase the risk of osteoporosis. I think my main concern in this case would be the cardiovascular risk, right? But again, we do know that 2.5 is probably very safe. I would probably just give it a trial, but I would drop the levothyroxine properly, so just to make sure that I don't bring the TSH below 1. So I would probably do more of a ratio of 1 to 15 or 1 to 20, rather than the usual that we do. You know, sometimes we do 1 to 7, 1 to 8, sometimes we do 1 to 5. So I probably would just drop the levothyroxine properly, add 2.5, give it a trial of a week, which is because T3, the effect you'll see next day, if not the same day. So it's not like levothyroxine when you give it and you have to wait 6 weeks to normalize the TSH. Levothyroxine half-life is like 1. You really don't see the good effect until 1 or 2 weeks later. Versus T3, where you take it now, an hour later, it's different. It's really the cost. But the difference is so I would probably just use a 2.5, kind of like give her the benefit of the doubt and check her back again in a week. If her symptoms are not affected, I would stop.
Thank you.
Not finding it.
That was the second most
Is
important
anyone
question.
who will not get?
It's
Is anyone?
unregistered.
Where, where to find it then?
Does anyone will not get for this question? Those is very great. I don't know myself. I don't know.
Where is it available? This is
Cytomel.
Yes, Cytomel I know.
Cytomel is, I mean, it's only present in the American Hospital Pharmacy. When I used to work there, they had it, and now I saw a patient at Blue Care and I sent him to get it from there. It's unregistered, those insurance will not cover it. You have to pay out of pocket for it.
People who have symptoms, debilitating symptoms, they want to try and they will.
Yeah, in the States, it was very much available.
Yeah.
25. 25.
25? Yeah. And so it's a tablet, so can you break it? You can break it.
I have another question. I think anyone can answer, Dr. Karthik or so. I have a young male, 46-year-old male, recently diagnosed with hypothyroidism. Initial PSH 18, TPO, TG antibody positive classical case of Hashimoto's thyroiditis. I started him on 50 microgram levothyroxine. He had severe palpitation after that. There was no adrenal insufficiency, nothing. Tried with 25 and even with 12.5 persisted to have these symptoms. How do you know such a case? Have you?
I would give it to something that blockers for him. I mean, 18 is not that hard. I would probably just give some beta blocker for symptomatic relief and then taper it down. You know, but he needs it. He needs to put the vaccine. It's very common actually. I see a lot of it. Because with hypothyroidism, what happens is that they go bradycardic, right? So even going
Suddenly, like,
living in the heart of 50 and 55, and then suddenly now with 70, they feel that it's too high. So I
like
probably
normal
would
glycemia.
reassure them that it's going to be fine. It's just you adjusting to the new norm. A little bit of propranolol. I mean, I would probably not use propranolol because it would affect the conversion, but maybe some alcohol in the background. And then once you think it's lower and the patient is tolerating the medicine, that's just take it off and for a stop
Yeah. Sarah, one option is for us to get Lionom from back home. That's it's available easily in India. Yeah, yeah, it's
The different side of the spectrum, we reported, we published basically in Fuji and Oxford, just before I relocated to this country. 2003, I think, yeah. There was a 57-year-old lady who primary autoimmune hypothyroid, and we started her with 50 micrograms. 50 micrograms. And right away, she started having diarrhea. We would call the diarrhea soon after thyroxine replacement. Me and Dr. Bowen Charles and other guys there from Liverpool. So it was difficult to know why 50. I mean, she's definitely, TSH was 16, if I remember right. And after that, we stopped it. I mean, just to cut the story short. We checked for even endoscopies, celiac, we did everything, biopsies, you name it. So at the end, it was a mystery. We stopped the thyroxine, was 50, and the diarrhea disappeared. Then Paul Jones asked, okay, let's restart at 25. We start at 25, again, reproduction of the symptoms again. So, what's going on here? She needs thyroxine. What's the reason?
typically lactose intolerance shouldn't be
Lactose is excluded.
excluded.
I was thinking about that.
Changes the preparation.
Yes. It was the preparation itself. So we have to get her purified thyroxine
Okay.
from Martindale Pharmacy in London.
Okay.
We managed to get her the right dose.
Change the preparation.
Yeah. So it was the
Yeah.
ingredients. So I just want to say that if you have trouble with thyroxine, think about the
Could be the
preparation.
same issue.
So you can again, it's QGM 2002, 2003.
The other end of the thing is
find my name.
the commonest reason for doing the LT4 absorption test back home is that people taking government supply thyroxine, they would need sometimes 400 micrograms and become hyperthyroid on 100 micrograms of actual thyroxine. You can imagine what is there inside the government supply tablets.
Is anyone try this once weekly dosing? Anyone?
was very common back in the States. We see a lot of patients who didn't take it. We bring them in once a week to take it.
And what was the result? A non-adherence was?
Yeah, I'm like-
Was a non-adherence, yeah. Oh. Curious. But for this patient, Dr. Harun, which will get, if it is above, above 60, and I don't have guidelines to support using T3, as though it's not a part of routine, I will avoid myself. Yeah, it's okay.
Now that the 60 now.
Well, actually, it is not.
60 now.
No, still in our community. No, but still 6 now. Community not like still all danger.
You know, I had a patient.
I don't know.
I had a patient that he still, I think it was a fellow back then, presented with mixed edema coma. And we started him on levothyroxine and levothyroxine. Because it was listed in the guidance not using levothyroxine in those patients. And he improved his mental status, got better, he was awake, communicating, so we stopped obviously the levothyroxine, continued with levothyroxine, within days he was back to his and we couldn't explain it, like his TSH was better. So we checked his T3 in the blood and it was very, very low. He was literally not converting anything to T3. We restarted the levothyroxine and his mental status improved, he woke up again. So we waited a little bit and we stopped it and he went back into his fever, which was really interesting.
Very interesting. But also, to that effect, we need large number of patients. Well, it could be.
But it was interesting to see like.
No, I myself, I used to speak to some patients and they say we have marvelous life like that. But I myself, I don't believe. I give them and they say we are very nice. I need them, but I have number of patients. Huh?
They need a special clinic because they need a lot of time with them. Because in the cardiac MDs, you met Vinay, right? Vinay and Colin Dayan, they used to run a separate T3 clinic. We used to send all these patients to them, so they are the sixth endocrinologist.
Also, I like what Dr. Ali mentioned, symptomatic prediabetes. Because in practice, we have some patients, yes, I feel I'm diabetic. Like diabetes, I feel I'm afraid do the lab for me, and when we do, I go polyuria, fine, like that symptoms. And when I do for him lab, I find prediabetes, not diabetic. So it seems there is some osmolarity symptoms. We see it in practice.
This is a practical point.
Yes, thank you, Dr. Ali. Any last question?
So where are you getting T3 from? America only?
It's an American hospital, but first time I go in the American. We go there. So last question. That's my question. No.
What's the UAE label indication for metformin in pediatric patients? It's approved FDA for diabetes in children more than 10 years old.
Yeah,
But what's the age cutoff for diabetes?
Yes, this is
in
a good
pediatric?
question. I don't know, but I use when I see the patient. Over 10 years old, I use it. Right.
Because now we have so many patients with the.
Yeah. I am not sure if there is UAE label. Maybe you guys know. For metformin in the
The
pediatric.
pediatric
UAE label.
UAE.
We use it above 10 years.
Above 10? Yeah,
What
what's his
grade
other?
That's pre-diabetes.
What's his other?
But UAE label.
What I know is above 14.
FDA is more than 10 for diabetes, but not, I'm not aware about the pre-diabetes.
No, I am. What I'm saying, using metformin safely in children above 10 years. These are pre-diabetes. No. No. Last question. Finish? Okay. Okay.
He
Thank
cleared
you.
the cardiac
We need
problem,
to take just
and guy didn't have any heart problem or anything.